A lot of questions came in. Please, we also have the microphones here. Atul, let me throw this one to you. I think they didn't read your paper with the river of spa, with the little tributaries coming off of it. Do you consider non-radiographic axial spa as a truly different entity from axial spa, or merely a gradual progression?
Yeah, thanks, Artie. I actually did answer some of these questions in the chat, but I will re-answer it again on the live for the live audience. So, non-radiographic axial SPA is a subset of axial spondyloarthritis. Axial spondyloarthritis is a larger term. It has got non-radiographic and radiographic, and the distinction totally depends upon the degree of sacroiliitis, as I said. So all ankylosing spondylitis patients were non-radiographic at some stage in their life, and they progressed from non-radiographic to ankylosing spondylitis.
Okay. Denis, John, anything different?
Actually, I want to throw a question with what Atul just said. So this is actually to Atul and to Denis, okay? And that is the classic study was just done, which was re-examining the axial SPA criteria with a really elegantly designed study. And I wanted to see what Atul and Denis think the impact of that study on how we define AS and versus non-radiographic for disease.
Well, we are going to be publishing the results at the EULAR meeting, and currently it is under embargo. And I'm very hesitant to say anything about the classic study because I am on the steering committee of that study. It's a very important study, and for those in the audience don't know what classic study is, this was a combined Spartan and ASAS undertaking. 500 patients from North America, 500 patients from rest of the world who were referred to rheumatologists with the suspicion of axial spondyloarthritis were examined, history taken, examined by, and all patients underwent X-ray and MRI and HLA-B27, C-reactive protein. The idea of the study was to validate the 2009 ASAS classification criteria. And there was an a priori decision that we need the sensitivity to be 75% and specificity of more than 90%. And if we find that the sensitivity specificity of the 2009 ASAS classification criteria will not, it's not 75% sensitive, 90% specific, then the criteria will be modified. That is the premise of this study. That's why the study was done. And as John correctly said, this is a very, very well done study. This was all expert centers in the US, Canada, Mexico, and rest of the world. And there is a whole session on this at the EULAR. At this time, we are actually looking at the data. We are analyzing the data. There are a couple of meetings, 2 more meetings planned. Something will be given to the Spartan people at the Spartan annual meeting. But beyond that, I don't really want to say what the findings of the study are at this stage. But keep your ear to the ground. Good information is going to come out of this.
Come on, Atul, you can tell us first at RheumNow Live. Oh, what the heck?
Yeah, my question to was really if, not what. Do you think that there's going to be possibly changes in the way we look at this?
We will see. We shall see.
Yeah. Here's a question for Denis. There was one of the things that we used to talk about is response to nonsteroidals, and there was an interesting abstract from EULAR, I think it was your group, that showed that actually that's a urban legend, that whether or not people's back pain does better to nonsteroidals does not differentiate people with axial SPA from those with mechanical back pain from those with generalized pain. Can you comment on that?
Yeah, I can comment on this and also maybe on a little bit on classic study because I've been one of the central imaging readers in this exercise. So regarding response to non-steroidal anti-inflammatory drugs, the issue is that the response to NSAIDs together with other features is suggestive of inflammatory back pain, is often used as a referral parameter. So a GP is seeing a patient in front of him responding well to NSAIDs with some back pain at night, maybe a little bit of morning stiffness, and he or she thinks that that might be axial spondyloarthritis and refers the patient to a rheumatologist. And at this time point, the diagnostic value of inflammatory back pain or good response to NSAIDs is already used and implemented in a certain level of pretest probability. So in this patient, the pretest probability of spondyloarthritis would be not 5% anymore as in patients with just chronic back pain, but it will be around 30%. This is a good thing. The bad thing is, for us, for rheumatologists dealing with that patient, response to NSAIDs or inflammatory back pain doesn't differentiate anymore between inflammatory and non-inflammatory reasons of back pain. So you need to know which patients are referred to you and based on which criteria, and then you would be able to estimate the diagnostic value of a single test. But just response to NSAIDs is one of the many pieces of the entire puzzle. And concerning the classic study, I need to say we learned a lot over the past 15 years how to improve the diagnosis of axial spondyloarthritis, and the major progress has been made in terms of imaging, and what I was trying to present to you, more or less state of the art. How do we look at images at 31? What are the technical requirements and so on? All these things were not available at the time point of 2009 classification criteria. So there might be some refinement in terms of which lesions should be considered as compatible with axial spondyloarthritis if we want to diagnose and later to classify patients.
Okay. There's a question, Atul, you mentioned about blue-collar work. What about the relationship, and John mentioned physical stress, the relationship between physical stress and blue-collar work and the development of inflammatory axial disease?
It's actually, that's less the issue than is the likelihood of ending up on disability. That blue-collar workers, this is work that Michael Ward showed, that we showed it in our SOAS study and the like, and it's been shown also in Europe by Annelies Boonen, that people who are blue-collar workers, people who have engaged in heavy manual labor, are much more likely on developing AS to end up on disability than those who are having white-collar jobs, which is why we get these young people coming to us early in the disease course, we try to counsel them against that. Look for an office job.
Atul?
Yeah, this is a quite common question asked, is that we actually tell our patients with ankylosing spondylitis to exercise. And at the same time, these blue-collar workers who do physical job have much worse structural progression. So are we doing it wrong? And as John said, Michael Ward has done many studies, a couple of studies in the past, which showed that recreational exercise, physiotherapy, regular exercise, those are all good things for patients with axial spondyloarthritis. And blue-collar job, I mean, that is kind of excessive amount of structural work that may be detrimental. We in 2019, those ACR treatment guidelines, when they came out, we did not really want to open the can of worms, because the question is then what exactly do you tell your patients? Change your job or go on disability or what? And so there are data to suggest that patients who do excessive amount of physical activity, and again, the definition of what is excessive, what is not excessive, one can argue about that. Recreational exercise, good. Physical therapy, good. Staying active, good. Excessive exercise, not so good. And I'll leave it at that for, and John made a very good point that these people do become disabled earlier because of their disease.
And obesity, very, very, very bad, both with treatment response and outcome.
Okay. There's a number of questions about the imaging. And Atul, you presented this. Denis, you presented this elegantly. And people are asking, well, my radiologists are not so good. So until AI takes over and chatbot makes all of our readings for us, what do we do?
Yeah, good question. And I think there is no other way except looking at the images by ourselves, because we're doing ultrasound. So why shouldn't we look at images from an exoskeleton in our patients? And I see a substantial progress made in this area, and I start realizing that rheumatologists, at least in terms of differential diagnosis of axial spondyloarthritis, are performing on a mean level already now better than just community-based radiologists. This is the reality. At the same time, we're trying to approach also radiologists. So we last year we developed a set of recommendations for information exchange between rheumatologists and radiologists, and this manuscript is intended for publication primarily in the radiologists journals. We aim at dual publication. And finally, right now we are testing a central platform where rheumatologists from Germany are able to submit their cases for, so to say, central readings. So Xenophon and I were looking over those cases. We developed that as a scientific project to prove is there an added value of that centralized reading. I need to say I'm working right now on interims analysis, and it seems that we are facing right now a problem of over or misdiagnosis of axial spondyloarthritis, which is even larger than a problem of missed cases. So we need to work on this, and if this exercise is successful, it might be a model also for the future.
Okay, we have a question here live.
Okay, this is kind of a case study. 31-year-old male, type 1 diabetes. He presents with nephrotic syndrome, hospitalized for 2 months, significant muscle loss, comes to me in severe pain and stiffness. On exam, the stiffness is axial and proximal, but it seems to be muscle rigidity rather than spine or joint. His CRP is elevated, but he's still coming down from nephrotic syndrome. MRI shows bone marrow edema in the vertebral bodies and in the ilium. I called the radiologist. I'm like, what am I supposed to do with that? And I said, could this be related to the nephrotic syndrome? He said, absolutely. So I thought, okay, we'll wait and see if the CRP comes down. 2 months later, CRP normalizes, bone marrow edema resolves. Stiffness is improving on low-dose naltrexone and ketamine, nothing else, and physical therapy. His pain is well controlled. He's feeling well. His dad, though, has true ankylosing spondylitis, disabled, bridging syndesmophytes. I mean, just the obvious. His dad looks like the prototypical AS person. So I checked the HLA-B27. It is positive. And I'm thinking, well, what do I do with this guy? And I can't put him on NSAIDs because of the nephrotic syndrome. He was on steroids for unrelated condition. I said, how did you feel on the steroids? Did the stiffness get any better? The back pain, joint pain? No, had nothing to do with it. Stiffness isn't worse in the morning. It's all day. And endocrine doesn't want to do a trial of an immune suppressant because of the type 1 diabetes and recurrent infections. Then I find a rash on him, and it looks like psoriasis. And I'm thinking, oh, great, psoriasis. But I thought, I want to be absolutely sure. So I sent him to derm. And they do a biopsy. Biopsy is consistent with eczema, even though the location isn't consistent with eczema. But derm doesn't really trust that either. It biopsies them again in another location 2 months later, still comes back as eczema. So the kid is comfortable. His rigidity is improving. His pain is well controlled. The edema is gone. The CRP is normalized. But with the family history with dad having significant AS, I mean, right now I have him on 6-month follow-up, and I said, if anything changes, if anything worsens, come on back. And no uveitis, no inflammatory bowel symptoms, no enthesitis, none of that. I guess, would anybody suggest doing anything else differently?
Well, I think you send him to John.
Yeah, that's a tough situation because there's so many confounders at play here. First of all, obviously, and Denis and Atul will be the first to iterate that MRI changes in the spine are not particularly specific for spondyloarthritis. You didn't mention the SI joints. Did he have bone marrow edema in the SI joints?
Nope, SI joints were clean.
Yeah, so I would not put too much weight on that particular findings. I mean, that, though, being B27 positive, having a father, and from the work done, Wasim Khan and many others, that we know this phenotype can even certainly occur in the absence of radiographic changes. And it sounds like, if we're talking the SI joint, the absence of MRI changes, makes it suspicious, although I don't think at this stage of the game you've confirmed a diagnosis of spondyloarthritis. And you say he's doing well now?
He's doing well. And
how much the prednisone is he on?
Oh, well, he was on prednisone for an unrelated condition. He ended up getting bronchitis and was on 2 weeks of prednisone, and there was no change in his pain or stiffness whatsoever.
So he's off the prednisone?
So off the prednisone.
Thank God. Okay.
Yeah. Now, I did have him on low-dose naltrexone, and during that time, CRP went down and the bone marrow edema went down, but I think it was just because it was 2 months post-discharge from nephrotic syndrome. So I don't think that was related, but his pain has improved. GAD antibodies were negative. So, I mean, the presentation was more like stiff man syndrome in a type 1 diabetic following nephrotic syndrome. But then I had the HLA positive and the dad with AS, and then the rash that looked like psoriasis, but apparently it's not. I'm like, what am I supposed to do with this guy? But he's doing well.
He's at risk. He needs to be followed. And for appearance of more classic features of the disease will help you to decide specific treatment.
Okay, and that's where I'm at. 6 months follow-up unless he gets worse or develops new symptoms. Okay, thanks.
Let me throw one last clinical question here out at our experts. This one got upvoted a lot. Ankylosing spondylitis, acute uveitis, who has failed multiple TNF inhibitors. Denis, what's your go-to in this situation? Obviously, other than the steroid drops and...
Yeah, difficult situation. So we do not have convincing data regarding IL-17 inhibitors. So probably at the dose we are applying, they're not very effective against uveitis, acute anterior uveitis. But a treatment could be a JAK inhibitor. So they have very limited data, but data which are available for filgotinib and most recently also for upadacitinib indicate that they might behave in spondyloarthritis like TNF alpha inhibitors, decreasing the risk of acute uveitis flares. You might also consider combining TNF or JAK inhibitor with a conventional synthetic DMARD such as methotrexate. Excellent.
Atul?
I would agree. Methotrexate, sulfasalazine is something I would try. Ophthalmologists might actually give an injection of corticosteroid in the posterior part of the eye and all kinds of stuff. But JAK inhibitor, there are emerging data. IV IL-17 inhibitors might. There is one study on secukinumab, IV secukinumab in uveitis patient, which was successful. We don't know whether there is another IV study in axial spondyloarthritis going on. We don't know whether that will show whether this drug is going to be successful for treatment of or reduction in flares of uveitis. Currently, I would agree that beyond TNF inhibitors, monoclonal antibodies, we don't have a biologic or a novel synthetic DMARD, which has definitely shown to be working for uveitis. But all of these are one can try.
John, you get the last word.
I have a huge experience using, and I have no relationship with the companies that make JAK inhibitors. I have huge experience using JAK inhibitors in these complicated AS patients, and I find
With
that
uveitis specific.
even with uveitis, although there's not a lot of great data with uveitis that are published at this stage of the game, but I want to underscore something Atul just said, that some of this IV IL-17 inhibitors, although IL-17 inhibitors are not supposed to be as effective against uveitis, deserves a fresh look.
All right. Well, with that, let me thank our experts, spondyloarthritis panel.